Good afternoon, everyone. As always, we're early because we're so good like that. Dr. Dom has been at women's only seminars all morning. So before the chat pops off and we get questions rolling in, I want to be hearing what Dr. Dom learned this morning so we can share it.
Well, let's just talk about what it was. So it was a 24-hour webinar or web seminar that was online where 3 hours were done with each country. So
That's
Australia,
so cool.
Asia, Europe, the whole world, there were women psychiatrists getting together and sharing on this webinar. And so it was connected to International Women's Mental Health Day. So we can now be two women also contributing to women's mental health. But God, just hearing women and these very strong, women with all the information, just constantly raising the
So
differences that we need to bring.
inspiring.
It was incredibly inspiring. But then also just brought up how far we've still got to go. So, I was
Depressing.
listening to one of the professors, Jayshree Kulkarni. She's just been at the forefront of thinking about women's mental health. She's been one of the biggest movers in
Hi, Chris. I'm so glad you're here.
It's very late for you. Thank you for coming on. She's been, one of the absolute pushing for, interest in hormones and women's mental health. But, a couple of the really big, things to be thinking about is just even the most simple things. It's once you start looking at through that gender lens, we've talked about equality and stuff like that, but that's ended up with things like mental health wards with men and women in together.
That's crazy.
The majority of the women are there for trauma-related conditions, because that is the reality of what we were talking about today, is how much of women's mental health is directly related to trauma.
You can't have men and women in a mental health ward together.
And we're not just talking about, we're talking about people who are dysregulated, emotionally dysregulated, and then putting them in with traumatized women. So
Can we also can I say the BPD thing? The BP.
Yes.
Can I say I don't think BPD is real,
look,
and that it's just traumatized kids are well.
they're better. They're over there with their
My
screens.
question from last week get answered. Gracie, I have it written down.
Where is it?
Let me go back and find it.
Thank you very much for coming back.
I thought I answered it, but Gracie, do you want to drop it today?
There was some,
Just in case I can't find it in my list. Oh no, I've got Grace. How can I tell if I have ADHD?
Was that
But
it?
I could be wrong. If you want to drop it again.
Yeah, so there were things that were just incredible in this seminar. All of the medication that are used for substance abuse disorders were only treated, tested
it was
in
that.
men.
Yeah, only tested in men.
Okay, so the question was about how do you know if you've got ADHD? It's the first big thing is the attentional differences. It's being aware that you have a capacity that intellectually you understand something, but when you sit down to read or study or in a lecture, trying to hold your attention on what is being said. People can describe it as just feeling like their attention's constantly being pulled away. And then all of the different things that come related to those attentional differences. One of the big ones, so the big ones we look for in adults as compared to the kids, which often have a lot more of the behavioural and hyperactive things. For adults, how are things going socially? Because one of the really common things is I really struggle in group situations.
Everyone is saying I have ADHD, but I've been diagnosed with CPTSD.
Okay, yes. And
there's commonality.
Yeah,
there's
commonality.
There's misdiagnoses and there's comorbidities.
Yeah.
So they can occur at the same time.
And this is why, we're really working.
Thank you, Chris.
To emphasise how important it is to get really good assessments for ADHD, because we know that there's a lot of things that affect attention. And that's very real, but they're not all ADHD. And Gracie, thank you very much for sharing. Complex PTSD, the attentional side of things is a really big part of the everyday functional side of things. It's where, because your brain is kind of going with that, it's not safe, even in the present, it means that your system's wanting your attention to constant, we call it in that kind of hyper alert, it's that meerkat kind of, where's the danger, where's the danger, where's the danger? And I often say to people, if anything, when we're dealing with PTSD related attentional difficulties, is that your brain's literally going, you want to do what? You want to sit and study or read a book or, something when you're meant to be looking for the danger behind you. So it is a very, very big feature.
When we've got Jess saying, do you think BPD and narcissism can go hand in hand? They're both cluster B diagnoses, aren't they, Dom? They're both cluster B.
Yeah.
So you get a lot of different features from cluster B that occur. Like if there's a Venn diagram and you've got like narcissism, BPD, etc., there's a lot of cross things happening, so they can go hand in hand. When a woman's diagnosed BPD, I don't think it's real. I think that she has trauma that hasn't been solved. But just my opinion. My opinion.
I'll take it to that there are some people who do actually have what we would call the classical BPD, but it is very, very unusual. It's a very, very something where they're very clearly unwell with it, and it goes well beyond what is generally where that is being diagnosed. What we were talking about today was that it's basically anyone who presents to an acute hospital with issues related to self-harm or emotional dysregulation is being given a diagnosis of borderline personality disorder. First of all, it's not something that can be diagnosed just on those two features, but they are also, the core features of somebody who's in an acute complex PTSD dysregulated state.
But Gracie, keep investigating it, keep exploring your own neurotype. Talk to your GP, talk to your psychiatrist if you have one. Guys, as always, the rules, we can't give any personal medical advice. It's general discussions only. Unknown user, contamination.
And I'll just finish up with the whole ADHD versus complex PTSD. Sometimes people can be a bit disappointed because they think that ADHD means, oh, look, I can get a medication and it just gets better and it won't be a problem anymore. The thing, though, is about, with complex PTSD, it is longer treatment, but the treatments that was one of the things coming out of the webinar this morning. They're effective. They work. We can treat trauma very effectively nowadays and really get a person's brain set right back to that it is safe, I can thrive, and then your attention comes back. So that's
guys, whenever I'm looking down, it's because I'm writing your questions down.
Okay, so what other questions have we?
Okay, so next we're doing unknown who had contamination, OCD, extreme germophobia.
Yep.
It's intense and I get made fun of for them. Ditch the shame.
Yes.
Don't worry about what anyone else is saying. This is your brain. Dr. Dom, your thoughts on extreme OCD?
Look, it is a really, really distressing
shock luck. I've written you down.
Particularly with the contamination ones, yes, it can be very obvious
Jess,
to others.
I'll add that.
Often people have got a lot of issues with their hands related to the excessive hand washing or wearing gloves outside. It is a really distressing, really limiting, really limits a person's, hours a day often it's taking from people. It is one that will, can be very responsive to a combination of both medication and therapy. And but it's also, just about, people being kind. People tend to kind of look and say, oh, look, you could control it if you wanted. One of the most distressing things about OCD is knowing it's an obsession but still not being able to control the behaviour.
It looks like that will move into, maybe in the next DSM, into a neurotype. So please ditch that shame. Postpartum
my view on
anxiety
EMDR
tips.
therapy. EMDR therapy is now got very good evidence base. It is very effective. It's a fascinating one. I've talked a bit about it on previous lives, because when it first came out, it just seemed so weird. How on earth could it possibly work? And then we did the studies were extensive. It does absolutely work. And why have we gone dark?
I don't know.
Can people still hear us? Are we coming back? And the other thing is that we actually now know the neural networks. We know where the eye movement part of the brain connects to the memory part of the brain. So it actually does now make a lot of scientific sense.
We've also got a question from Shaklak about treating depression
Yep.
without medication.
Yeah.
So ways to treat depression without medication.
Yep. So we've got a lot of effective therapies for depression.
Nikita, we're getting to you.
And as long as a person's not so deeply into a depressive
Danny Ray,
state,
that's a tough one.
that their brain's no longer going to, they're not actually well enough to even be able to interact with the psychological therapies, then, there's a lot of really effective ones out there. Mindfulness-based CBT, so that's actually working with teaching mindfulness and creating a different relationship to the negative thoughts. And then we've got ACT, acceptance and commitment therapy. We've got
Jess, I did get the POCD and that is written down.
Yeah.
We'll be doing that just next.
And we've got a lot better understanding of that kind of combination of getting the body moving, so bringing in, why does exercise, or what I often talk about now, much more joyful movement, anything that brings you kind of pleasure, or when you're deeply depressed, or at least not being a really
don't drag yourself to the gym if you hate the gym,
No.
but walk your dog.
Yeah.
I'm a getting a dog solves everything. G'day, Lisa.
They are actually incredibly good for your mental health. Okay, what else have we got there?
Okay, so Jess, just to comment on your ex-girlfriend with BPD. Personal opinion, she kind of sounds like a bit of a... Just saying. Nikita, any tips for postpartum anxiety?
Oh my goodness! Look, we are just really starting to really understand.
Just my thoughts, Jess.
Of the effect of hormones on the brain, and they are very much neuroactive. Post-pregnancy is this immense shift in hormones.
The
very,
greatest
very quickly,
hormonal drop in any mammal on the planet
over a few days. Yeah.
Is that 72 window after you give birth. It is huge. Don't underestimate it.
Yeah. And then you've got a complete disruption to your previous identity at the same time of, depending on the early period, you're going to be sleep deprived. There is no avoiding the sleep deprivation.
Lisa, I read your DM and we'll get to it.
There's a lot of really good treatment out there for it. It is now really recognised, and it's something we really emphasise. Get in and get help early. Don't sit at home feeling ashamed about it. And the anxiety often will really kind of emphasise shame. Get the help, because that means, we can get it managed earlier. We can get people feeling a lot better earlier.
I remember going into, my son was 2 weeks old and I went into my GP and he had me fill out the little questionnaire. And then one of the questions is how often do you feel worthless? And I was like, all the time. And he looked at me and he looked at my tiny little beautiful baby in the pram and said, I don't think he thinks you're worthless. And it's just, you're going through a lot. Be gentle with yourself. Be kind with yourself.
Connect to other parents who are in the same time frame.
Yes.
Because so many of the times, I was lucky enough to have a friend who had a baby 3 days before me. And
Same.
the whole way along, it's just been, what about this? Is this happening for you? And it's not doing it in isolation. It's really hard nowadays. We do spend a lot of time on our own
Get
with
used
our
to
babies.
it, Chris.
But that absolutely sharing it. The other one I'd really strongly recommend to anyone who's just had a baby is a thing called Circle of Security. It's a program that's available worldwide. I hadn't heard of it before I had my and oh my goodness, I was so impressed. I still use it now. I've still got the handouts from it on my fridge 8 years later. I use the language all the time. It's just got the most beautiful way of helping with that sense of I'm not doing it right. And really helping us understand, first of all, default parenting, but also how to do repair. It's just beautiful. So check out Circle of Security.
Millie 96. You've just gotten out of a DV marriage. They'll use anything you've said to a doctor to use against you to say you're an unfit parent. That's a really complicated question. We really can't get into that because there's a million things you could say to a doctor. But I'm so sorry I can't help you more with that, but please be honest with your doctor about whatever it is you're feeling and whatever you need to share. And
look, if anyone who's just come out of a DV relationship as well, use the DV supports. Ring up
document everything.
But look, a lot of the DV counsellors, they've had lived experience. They've been there, and gosh, they want to help other women just as much, as themselves.
Brody, for some people that can cause psychosis. Yes.
Yeah, they are right on where the systemic issues make it really hard, and where there can be ongoing abuse through parenting and custody issues.
Now, can we move on to a question? This was a while ago from Danny, but it was about being neurodiverse, having neurodiverse kids, and having difficult grandparents.
Oh gosh,
how do we deal with that?
Oh gosh, I'd love to know how common this is at the moment.
I think it's huge.
Because we've got this beautiful thing happening where families are just starting to kind of look around and kind of share, one person gets a diagnosis, suddenly everybody's having a look.
And look at your grandparents and go, y'all are autistic, shut up.
That's where we're then dealing with people who may not be able to actually shift their understanding of the word, what it was.
Faith, I've got you written down.
And then we're coming up against, where people are feeling unvalidated. It's a really tricky thing, with older people, how much capacity do they have to change their mindset? Some are amazing. Some can. Are incredible in how much they will embrace that. And I do I know it's helped me a lot personally to kind of just really kind of what's a person's capacity to actually change their thinking. And the older they are, the harder that's and the lived experience they've had of a different way of thinking, it does make it harder. And that sometimes helps just that kind of what's actually possible.
Jess, I might have missed yours because my next one was, is there a test for schizophrenia?
No blood tests, no scans. We don't have scans or blood tests for any of the mental
Jess,
health.
I'm so sorry. Yes, so we'll do schizophrenia, then we'll do POCD.
Yes, and it's a real issue in psychiatry because we are making our diagnoses based fully on clinical.
Hey, Daly.
Clinical presentations where we don't have those tests to back us up.
Abigail.
Okay, so what was the next one?
So we've got Jess with a question about POCD. I'm not familiar. POCD, John?
Yeah, I'm just the fact that we now have a term called POCD, I only recently discovered that it's become such a common term to be used out there, and I am so happy to hear it. So it's people who are within their OCD, they're getting thoughts related. I don't know if I can say the word.
Intrusive thoughts?
Intrusive thoughts related to a very particular behaviour that starts with P. Would that,
got you. Yeah.
Is that a word I can say?
I think so.
So I hope I've got it right. It's pedophilia related thoughts. And
intrusive thoughts, that must be so distressful. I'm so sorry you're experiencing that.
but the fact that it's being talked about, the fact that people are out there saying this is a condition that is very, very different to people who actually have thoughts that would create risk, or we call them, there's a big difference between what we call ego dystonic, which is where you have a thought that is just awful and it tortures you, just the idea of even having the thought, versus people who are actually at risk or are more associated with those thoughts, where they don't find the thoughts unpleasant. We call them ego syntonic. It's a very, very different situation. We think in the OCD part of the issue is that it's actually the taboo nature, the fact that they are the worst possible thing that a person
they create the most extreme
that
thing.
is actually why the brain throws them up. It's that kind of back the front thing. It's one that I'm glad people are talking about more, because it's been such an area of shame, and we used to get so many people.
Ditch that shame, honey.
Who came in and were terrified about talking about it, had never spoken about it to anyone else. And what we're finding with this, with anytime you can share it with other people who've got lived experience of the same thing.
You reduce the shame.
You reduce the shame. You reduce the stigma.
Thank you,
you
Saki.
share and knowing that other people have the same thing suddenly makes it that, okay, look, it's not something that has any relation to who you are or your risk of offending. It does not relate across to risk of offending at all, if anything, So I hope that's been helpful, and thank you very much for asking about
and sharing.
Yes.
From Faith, we had the difference between bipolar 2 and BPD. I don't believe BPD is real. This is my personal opinion. I think it's untreated trauma, and I think it's medical misogyny. That's just my personal opinion.
Look, this one's, and it does relate into how difficult it can be sometimes to untangle these different diagnoses, and how important it is to really listen to a person's story, take time sometimes to really unpack what's happening. But literally in the talks this morning, one of the biggest things that was coming up was that if there's trauma in the background,
sleep paralysis is real.
We often see people coming in with bipolar 2 diagnoses, borderline personality diagnoses, and then when really unpacking, if there's been significant trauma there, especially early childhood trauma, is it actually complex PTSD?
Yep.
So because you can definitely get the mood swings and the hypomanic
Here's some water, baby.
behaviours, but that's more just a general thinking about it. If somebody's been diagnosed with that, they need to chat to their specific doctor who made that
And remember
diagnosis.
that a lot of these things are comorbidities occurring at the same time, or misdiagnoses occurring at the same time. I will give controversial opinions all day long. I'm not a doctor. I can say whatever I want.
And look, the other
I think it's medical misogyny and untreated trauma.
yes, and look, just to so
I said what I said.
So people who are coming in now, I've actually been on a webinar this morning, which was just incredible. It's running for 24 hours, where female psychiatrists around the whole world are contributing to this webinar, and just so inspiring, but it's just so great to have women's mental health really kind of centered like that.
Now, I think we should get back to questions, because we've got Alex with, should I see a psych for extreme anxiety?
A psychiatrist
Yes.
versus psychologist. Yes.
Yeah.
Yes. So one of the
Ishmatu, writing it down.
and look, if you're seeing a psychologist, have a chat to them about it. But one of the things to understand about the medications that we use is that if a person's in a really heightened state of anxiety, their brain actually goes into a really kind of stuck state. It's really hard to learn new information. It's really hard to learn, learn different ways of thinking. And it's also just that extreme anxiety is incredibly uncomfortable. It's a horrible, horrible state to be sitting in. So the idea of using medication to bring down the symptoms, bring a person back into what we call their window of tolerance, where they're still uncomfortable with the anxiety. It's not about just using medication to fix everything and then do nothing more. It's about using medication to bring a person into a more comfortable state where they've got more room in their brain then to work on the things that will manage the anxiety.
And lots of
long-term.
psychiatrists do psychotherapy, meaning
Yeah.
talk-back therapy. So don't expect to walk into a psychiatrist's office and them just offer you pills as a solution.
Depending on what country you're in.
My psychiatrist, we just do psychotherapy. We just do talk-back therapy.
Yeah.
And she's incredible. So, Abigail, how can I keep my room clean if I'm ADHD?
Oh my goodness, if you find out, can you tell me?
ADHD.
And my car. Please, the car's the
Timers,
worst place.
set alarms, write lists.
Yeah.
That's what I do. We had a
Look, in anything with neurodivergence, or whether it's ADHD, whether it's autism, or a combination of both, I'm learning a lot now about. It's first of all, accept the hardwiring. So
except there's nothing wrong with you.
That my brain is not going to ever find it easy to keep a room organised. It's just not the way it works. But what I find is that from that position, I'm actually in a much better kind of situation to modify behaviours, bring in systems, and actually get something that's a lot more functional. And my room's a lot better than it has ever been in the past at this point in time. So there's something real. The whole time, if you're fighting with, I should be able to keep my room tidy, you're just going to keep running up against problems. Once you kind of go, my brain actually finds this really hard, and then shift across to how can I make it easier given that my brain struggles in this area, a lot more opportunities open up.
There's been a question about derealization. Is that real? Yep, derealization is real.
And really uncomfortable. And I was actually, somebody was asking before as well about fibromyalgia and whether you can recover from it. All of the conditions, anything with dissociative aspects to it, any of the FND, fibromyalgia, any of those conditions that have got a big, component of chronic stress-trauma behind them, then that's where we need to be working at that underlying
We can't give
level.
personal, legal, or medical advice, but the fact that you're clean now, congratulations, that's amazing.
Great.
It's hard to see psychiatrists in Australia because we don't have enough of them. That's why.
Absolutely. I have, I'm just kind of, talking straight to the question. Somebody's just said, needs to be out of neurospicy vocabulary. Should be out of every single person's vocabulary. If you actually sit and try and work out when do you actually need to use it, it's really unusual. You can nearly always put could.
Do you know what FND is?
Functional neurological
So
disorder.
they wanted the differences between autism, ADHD, and FND?
It's... Do they interrelate? Are they often comorbid? Is that more the question?
Yeah.
Yes. So we are seeing a lot of FND in people with neurodivergence, and it's increasing in frequency very significantly. So functional neurological disorder, just to be clear, it's people have very, very real disabilities and deficits associated. Very, very real functional effects by it. It's just that there's not an actual kind of organic damage to a nerve or the brain. We think it's related to interconnection, to connectivity and integration.
I'm going to write down some of these questions. We also had, is it worth getting tested for ADHD?
It depends what your motivation is. So ADHD is the one that we can't prescribe stimulants unless somebody has a clear full assessment for an ADHD diagnosis. And just to be clear, ADHD also, for the formal ADHD diagnosis, we need evidence of symptoms prior to the age of 12. So we need that childhood history as well.
I'm going to keep it where the comment is, and we're just going to go down. How would you suggest handle outbursts of extreme anger with a child with autism and ADHD? Work out what their regulation is.
Yep.
What regulates that child?
Yes.
Is it physical hugging? Sometimes if they're having a meltdown, you being super calm. Is it? Do they co-regulate well? Do they regulate well alone? Do they like stimming?
And probably Hannah and I are both parents of neurodivergent kids. Prevent the outbursts. Prevent the outbursts.
Do what you can beforehand to predict
if you're
what's
talking
coming.
to anybody who's, you know, especially with young children, it's this constant internal look. Do I take them out? Do I expose them to shopping centres? All of these kind of things.
Your brain's always like,
But
what do I do this?
also then how can I limit the amount of time they're in sensory overwhelm? How can I limit the things that I know if they have enough of, they are going to end up in a meltdown? My little person has heat sensitivity, and so now I just make sure he doesn't get hot. And but that's detective work. That's been 8 years trying to work out all the different triggers.
Yeah.
And you've absolutely got our compassion.
And also, there's no such thing as a perfect parent. But if you're a parent that's thinking, "Am I a good parent?" Yes, you are, because bad parents don't sit around going, "Am I a good parent?" They don't care.
Yeah.
Darcy, I watch my nightmares like it's a movie, like I'm in it and I'm constantly being stalked. And I think they'd also mentioned sleep paralysis.
Yeah, that's because I'm not sure if you're talking about nightmares that are actually related to a traumatic experience. So just to a general kind of thing on that is that when people have had a previous trauma, the nightmares that they experience, the very distressing dreams that they have at night, they're actually re-experiencing. So they're literally where the brain is replaying the trauma. And so it can feel very much like it's something that you're watching. There is that dissociation from it. But it doesn't change the level of distress associated
Burning
with
Chariot, what could verbal dyslexia be a sign of, like switching up the beginning and ends of words?
It can happen. One of the things with neurodivergence is that we are now there are a whole heap of neurological differences that occur, and they may or may not be related with a couple, with the bigger kind of neurodivergent names. They might be individual, and what I'm just saying is the more you get to know your own brain, the more you understand that it is actually a different wiring in your brain, the far more helpful it gets, because then you can identify it, then you can be aware of it and not be ashamed of it.
Cherry, my daughter masks and school doesn't believe me. You shouldn't be ashamed of masking or camouflaging, as we like to say. Neurodivergent people do it all the time. The evidence is that girls start masking at the age of 2. And if she's at school, she's going to be masking. It's exhausting.
And the word restraint collapse, I think, is just such a helpful one. So this is where kids have been masking all day. They're really holding themselves together, and the second they get home, all of that restraint collapses, literally. And then we see a whole heap of different behaviours at home. And good teachers will know that. Sorry, teachers who are, I'm not going to say good teachers, teachers who are kind of like neurodivergent informed actually will know that that's a really common.
I was diagnosed with ASPD. Is there any help and support for ASPD?
I am hoping that there is going to be more and more about this area, and particularly as we just start to understand it. It's been interesting on social media that there are more and more people actually feeling comfortable coming out and talking about their lived experiences with it. It's been a really big area as to what are there therapies that can be effective, and it depends a lot on the person's motivation for therapy. But it's work, if you really are, if a person really is connected to the things that they lose through antisocial personality disorder, is what ASPD is, it makes a big difference then about their motivation.
Can we talk about the difference from Sandy? What are the differences between men with ADHD and women with ADHD? And then Leanne, we're going to get to DID.
In both ADHD and autism, we see much more masking in women. Masking from an earlier age. So we talk a lot about masking. Hannah and I prefer the word camouflaging, but
I'm like a chameleon.
but people do with ADHD as well, particularly kind of hiding their difficulties with executive functioning and things like that. One of the big differences that we are just starting to really become aware of is that women's menstrual cycles, the hormonal cycles,
We're on a monthly cycle.
actually make a really big difference. So what we know is that there are differences in symptoms across the cycle, and there's different responses to the medication across the cycle as well. So that's definitely something that's more...
We've got Leanne. I battle DID, dissociative identity disorder. How would you describe it to those who struggle to explain it to others?
It's an interesting, it's an area because, gosh, it had so much stigma in the past, and which is why we changed the name. And it's... it is one that people can find very confusing, and also not understanding that it is not a voluntary kind of switch between different aspects. There's a lot more kind of acceptance of how much, the whole idea of us having different identities within our systems is actually now being much more talked about and normalised to a certain extent. And obviously DIDs are much more, it's a lot further along the severity kind of experience. Often one of the things with any of the mental health conditions, but particularly probably with DID, is the more that people can feel that if they don't understand what to do when you're switching, then they can be much more fearful. And unfortunately, humans get mean when they're scared. And so often making sure that people you're with, not just letting them know what might happen, but also what would be helpful for them to do in that situation. People love having something that they can do and help with.
Yeah. Can we talk about Melania? CPTSD is a fine line between ADHD, true, false. Very different. I think ADHD girls and autistic girls and boys are significantly more likely to experience childhood trauma because of their vulnerabilities.
Yeah.
So that's why they're often co-occurring.
Yeah.
So very different, because CPTSD is not brain wiring, whereas ADHD is, but the vulnerabilities of an ADHD neurodivergent child makes them much more likely to experience something that will cause CPTSD.
They can have very, very similar presentations in adulthood.
Yep. Is it normal, Holly, is it normal to still be triggered by stuff that happened 2 years ago in a DV relationship? Yep.
So again, this was literally this morning, and I'm hearing this kind of talked about more and more.
Hell yeah, Danny.
That if a person has developed mental health related responses to trauma, so if they have PTSD, it doesn't get better on its own. Some conditions like depression, sometimes they will actually just resolve independently. PTSD does not get better without treatment. However, what we actually do have very effective treatments now. So it is one that really getting in and having that treatment, but it's definitely people can do a lot of healing after getting out of situations like that. But if there's a fully blown PTSD syndrome, then and sometimes people are self-treating using yoga, or there's a lot of mindfulness approaches and stuff like that, but it does need treatment.
Yeah. I just wanted to respond to Danny saying that I let her drop her mask on the way home. We often scream in the car for 20 minutes. Good for you.
I love a good scream. Shared screams are brilliant.
Yeah, I like a burrow.
Let all that pressure out.
I like a burrow under my doona.
Yeah.
Kat Coven, can you talk about EMDR therapy? So do you want to explain
Okay, so what
what
EMDR
that
therapy is eye movement desensitization therapy. And what it involves is that a person is sitting and watching on a screen or with a finger, whatever works, is just literally taking the eyes to the extreme of their movements, and just doing that rhythmically and constantly. And while doing that, then having the person access in a safe way a memory related to a traumatic experience. We don't go in and do that with the really big trauma experiences, but by doing it with experiences that are able to be managed safely, it shifts it in the hippocampus. So part of the problem with why does trauma continue is because the hippocampus, the part of the brain, it stores the trauma memory as still in the present. It doesn't process it through. It doesn't put it in the this happened in the past filing cabinet. So it's kind of the brain is responding to this is actually still happening in the present. All of the neurobiology is of it's not safe, the trauma is still happening. EMDR actually gets the hippocampus to pop that memory in the filing cabinet.
We had a question if smoking grass can make ADHD worse.
It's one that, it's such a variable substance because nowadays there's prescriptions with very different percentages of different compounds, very different kind of things out there. It is not one of the big ones out there that I am seeing a lot on social media at the moment is the combination of using stimulants and grass, and that is actually one that is really concerning for us because the combination can actually increase the risk of psychosis. And one of the things about psychosis is if a person has an episode of psychosis, it primes their brain to further episodes.
Yeah.
It is a really, really terrible experience for both the person and everyone around them, their families. But it takes a good 6 months to recover from a psychotic episode, and it actually primes the brain to have further episodes. So that is a really big one that we worry about.
My psychiatrist refuses to put BPD on my file because no one will want to work with you. I am pretty careful about when I put that. I work a lot more from a trauma-informed approach, and I don't believe in BPD. I think you've just been traumatized.
I tend to be, very cautious about, documenting unless someone comes in with it previously documented, unless it is so clear that that is the helpful label in that situation. And yes, there are actually quite a lot of doctors who actually limit their practice regarding BPD.
Holly, I was diagnosed with PTSD, never wanted to believe it. Also, depression, anxiety. It's been crazy. Like, I'll hear a loud thing drop or whatever and feel like my heart is dropping. Yes, these are very traumatic things.
And that's the hyperarousal we talk about and the startle response.
Well, do you want to talk about what hyperarousal is and what a startle response is?
So it's the startle response is exactly what it sounds. So it's where your system responds to a sound in the environment as if there's been a major kind of trauma. Hyperarousal is and it's that hypervigilance where you're constantly slightly in that kind of like, where's the danger? Where's the danger? You can't settle or relax into anything. And they're very understandable experiences in that they are literally where the autonomic nervous system is stuck in that slightly still on in relation to the it's not safe that's coming down from the brain. And, it can be a real challenge. One of the things people struggle with is, how bad was what happened to me? Or, and we are we're here to try and decrease the stigma because, people have a very particular idea of the type of trauma that you're allowed to have a response to or be traumatized
like what's
by.
Big enough for me to have a reaction to.
And it tends to be the things, the very physical, a car accident or
essay.
Or and these things are all very real traumas, but the things that actually cause the most disruption to our mental health chronic interpersonal traumas.
Isn't that crazy? Chronic interpersonal traumas.
And so what I do a lot of work with helping people understand is if you've got trauma-related symptoms, you have experienced trauma. You don't have to feel ashamed or judge or in any way.
Because you're not responsible for what someone else has done to you. They are.
And absolutely. And there's absolutely no shame in PTSD is actually the very normal and understandable response of a system where an experience has overwhelmed coping mechanisms, and no one's immune to it.
Kuro, hello, 35 and have first ADHD assessment Monday. Scared of meds, any guidance? So we can't give any personal medical advice, but please don't be scared. Go in, talk to a psychiatrist, give them all the information, be real with them.
Yeah.
You know, you have to go, you'll probably change meds many times before you work out what works for you. If you don't want to, no one's forcing you to take them.
No, there is no requirement.
They're not going to open your drawer and force that. I'm diagnosed with ADHD. I don't take any meds for it. Can you tell?
And we've actually, we've had such a flood of people coming in with late adult diagnoses. And,
Hey, Bonnie.
We're actually now starting to get more people where they are, they're after a certain amount of time going, look, I think I can actually manage this without the meds. It's a very personal choice. There are some things that make meds really important, particularly if safety with driving. It's whether you're getting burnout or not. The other thing is it's not just stimulants. We actually have for people who can't tolerate the stimulants, they can be a bit much for people. We've got non-stimulants that are very, very different in the way that they act. We've got 3, all of which are quite different.
Can we look at Blueprint, baby?
Yes.
I have a very dysregulated nervous system. What's the best thing we can do? The thing about this is it's different for all people, but what would you say as general advice?
Look, I'm going to share a resource that I've recently been, been working with a bit.
We'll talk about what chronic interpersonal traumas are. It's a woman by the name of
Deb Dana, Dana, and I think it's The Rhythm of Regulation, her website is called. But there is a thing called polyvagal theory, which is actually about understanding what a regulated nervous system looks like. And we're talking autonomic nervous system here, which is the one that runs your fight and flight and your bodily sensations. It's the one that creates anxiety and panic attacks and a lot of then, if your autonomic nervous system is dysregulated, it actually does then affect your mood, your capacity to think, your whole view on the world. So polyvagal theory is really helping understand the nervous system, and then from that it's how can you actually retrain your nervous system using that understanding. And she's got some great resources on that website, literally kind of helping with the language, understanding that we call it the polyvagal ladder, which is the different levels of dysregulation. And any of these things, Hannah and I, we're always, it's reduced having a dysregulated nervous system is not your fault. It's not something to be ashamed of. It will be related to experiences or not having learnt the skills to regulate. And
what's happening in the world
now? Oh, God, absolutely. Absolutely. Let's be real about...
There's a lot going on. I mean, people have been commenting it.
Have they? I haven't. Yes. Yeah. Look.
How do you not worry about possible war? It's a good point.
No, you do want to worry about possible war. This is part of what we're actually... I do a lot of this now. It's shifting it. There's internal worries and things that may or may not be helpful. But it is actually, our system is designed to have anxiety, to have low mood about things, to give us information, to help us actually process and, have reactions to external experiences.
Dom, could you answer this simple life? What is a chronic interpersonal trauma?
Any times where there's
they still use ECT.
Boundaries, where somebody's constantly breaking boundaries or not respecting boundaries, where there's a lack of autonomy in a relationship, where a person's not got that allowance of self. But then, then we start stepping up to where there is actually constant criticism, and we did one the other day. One of the things with people who are neurodivergent is parents, teachers will still bring in a whole heap of things thinking they're helping the person regulate their behaviour.
You're lazy.
But all it's doing, you're lazy, you're too much. Why can't you do why can't you sit
did it
on your
before.
chair
Why
straight?
can't you do it now?
And each and every one of them is traumatizing. It's a micro trauma. Yeah.
Do people still use electric shock therapy?
Yes.
Yes, people still use ECT, and it's very effective for depression.
Are there situations that we do not obtain consent from the person? Yeah, there are, because
For ECT?
ECT is actually the most effective treatment for the very, very serious mental health issues. So just to be clear, we talk a lot about depression. Depression can get so bad that a person gets pneumonia because they're not breathing enough. Depression can be so bad that a person is not moving at all. They cannot eat or drink. And so at that stage, we're dealing with a life-threatening medical condition. There is a level of mania that we get in bipolar disorder, that people stop sleeping. If that lasts for more than a certain number of days, it will be fatal.
Yep.
So we actually do have situations, and
it's specific laws that govern.
There are
specific laws that govern when you're able to do this.
And a lot of safeguards, and particularly more so around ECT.
Can I just say to Holly, we don't do personal bookings, but we do take bookings to speak to communities, businesses, workers about neurodiversity and mental health.
No, I'm happy to talk to this one back here. What happens when psychiatrists make wrong statements that contribute to your stress? Look, this is one that it is actually really important to talk to, because it can be very much, we're often running under time pressure. Not that is an excuse in any way, but it's really, and we're not also always going to get it right. And different things work for some people and might be something that really stresses another person. The most important thing is feeling comfortable, working with someone that you feel comfortable speaking up with them and saying, what you said just really caused me stress. Because the response to that then is, that's really important information. I'm so sorry that that's happened. Let's talk through why it's caused distress. And sometimes actually within the sessions, if we accidentally trigger something, that gives us the opportunity to work with it there and then in a safe situation. So it's much more about, do you feel comfortable speaking up and letting the person know that it's caused you that stress, and hopefully getting a really good response.
Karim, I'm just not going to respond to that just because we can't give any personalised medical advice. But Leanne, do you think Esther's emotional support stuffed animals can be helpful for those with anxiety? Yes.
Yes, well, look, I think that's one that people are being more and more open about. Kids are now, we're using weighted blanket animals so that they can take their deep pressure tool with them without it being so obvious.
Hat, I'm so sorry that happened to you. It's not your fault. It never has been, and I hope that you'll find some peace and support now.
I'll just talk a little bit more to that. At the moment, we, within the area of trauma therapy, we're still in a big, this has been something that we've made massive shifts with literally over the last 10 to 20 years, more so in the last 10 years. It was a really, really big fight to get people on board with it, and for a very long time it wasn't particularly accepted, but nowadays luckily trauma-informed therapy is becoming much more the norm. Unfortunately, there still are a lot of practices out there that we probably wouldn't be including into trauma-informed therapy, and it is an area where some treatments will work really well for people. Some treatments, need to be very different. Some people, the talking therapies work better. Some people, the body therapies work better. So if people are feeling worse with any treatment, absolutely talk to the person who's bring it up, share that information. but also, it's actually quite important to check when you are choosing somebody that they are trauma-informed.
I love seeing you all supporting each other in the comments. It makes me incredibly, incredibly happy. We are based in Queensland, Australia. I'm just... what happens when you are treatment resistant or don't find it works? We're going to have to pivot. We're going to need new treatment.
Yes. Look, it's a term that it's used medically. It's really helpful from a medical perspective, but it's really important that people explain it because it does have that bit of a connotation of what are you doing wrong.
Holly, writing it down.
It's often depending on if we're working with a particular medication, it's genetics often. It's how people metabolize a particular drug. It's how that drug's working on their particular neurotransmitters. Some people we can find it straight up. Some people we do, they might not be as responsive to treatment. We're here focusing on neurodiversity. There are big differences for people who are neurodivergent. For people who are autistic, they do not respond. So autistic anxiety has a quite different quality to the more generalised anxiety. It doesn't respond in the same way to the treatments that general anxiety would respond to. A lot of people with neurodivergence are far more sensitive to the medications. And literally this morning I was hearing about how the trauma effect on neuroimmunology and on the HPA axis, and that also affects how people respond to medication. So, there's a lot of different things that can contribute.
Is it
possible? We can generally do the detective work.
Is it possible to have memory loss after trauma?
Yes. Yeah.
You want to talk about why that happens?
Sorry?
You want to talk about why that happens?
It's a protective mechanism of the brain. So it's
Psychiatrist.
Yeah, it's two things. So one of them is a protective mechanism, but it's also that the chronic trauma state, that being in that constant fight, flight, actually our brains, and it's all about collecting information from the environment rather than laying it down, and it takes a bit of effort to consolidate memories. So that can actually affect memory creation as well.
Sorry, I'm just getting rid of that.
Yeah.
My son has anxiety and panic attacks, but in Queensland can't get him medicated the doctor would like. Yes, it's hard.
I'm not quite sure what, so here in Queensland, there's no restrictions on children having mental health medications. It is one, most GPs will be very cautious and will involve a specialist because the medications for anxiety and depression can have a slightly different effect in children, and very rarely can actually make things worse for children and bring in intrusive thoughts and actual suicidal thoughts. So when they're starting them.
Yeah.
So we have got a much
It's on
higher,
the packet.
It's got a kind of black box warning. It's a very serious thing to be aware of. So it does change our risk profile with using medication for kids, but it doesn't mean that we don't do it. We're just super cautious and make sure everyone involved is aware of those risks.
Official Tia, I am constantly depressed. What should I do? Firstly, please make an appointment with your GP. We can't give any personal medical advice. So please make an appointment with your GP, get a referral to a psychiatrist, choose a woman, choose someone you trust.
And also just while you're doing that, and it's really important to get the assessment and see if there's treatments that are needed from a medical or psychological perspective. But let's also, there has been a lot of comments coming up. There is a lot depressing about the state of the world right now.
Yeah. There's a lot going on.
And so,
there's an orange egg in the White House.
It is checking in with, is it an internal depressed mood or is it related to hopelessness?
Joker, we can talk about
about the state of the world
later.
And, there's a lot that you can actually be doing to to manage those feelings. You absolutely want to be acknowledging and respecting the emotions that you have related into a lot of the stuff that's going on right now, because that is actually the appropriate response
to an insane situation,
to, you know, the harm that's being done to people, to some of the news that's coming out at the moment. It is, you know, right now we've gone from having, quite a few decades of this idea of, the future's going, everything's going to continue the way it is, to pretty sudden change to we don't know what the future's going to look like.
Yeah.
But there are techniques and ways that you can work with that, and really working to actively maintain your hope, but also working to increase your connection in your immediate environment. I heard a wonderful female psychiatrist this morning talking about that, you know, bring it back to your backyard. Literally Hannah's thing. Hannah, she was talking about birds. She was talking about talking to your birds in the backyard. And I was immediately thinking about that. Yeah.
Chris has pinned this, so can we answer it? I have ADHD, but fairly sure I have AU ADHD. Any tips to see which one I have? I'm an AU ADHDer. If you're obsessing about it, I reckon you probably have the double whammy.
Yeah. There is a resource that that can be quite a good one if you're interested in just kind of reading more about it and looking into it more. We are getting a lot of people at the moment where once people are treated for their ADHD, it unmasks the autistic thinking, and the autistic aspects of their neurotype can actually become clearer at that point.
There's a
great book by a guy called Pierre Novelli. It's called Why Can't I Just Enjoy Myself? And it's brilliant. It is brilliant. This guy's a British comedian who got called out while he was literally on stage doing an info dump on his special interest, and somebody in the audience said, "Mate, do you know you're autistic?" And he went, "Of course not," and then spent the next 2 weeks doing an incredible deep dive and constantly researching it. At the end of the point, he went, okay. He's written a book on his experience, both of kind of really exploring and getting to understand his neurotype. It's a great resource, and it's a great one if you're kind of wondering to read and kind of go, well, how much does this resonate for me?
Lisa, if Lisa/I'm out of lorazepam, if you're still in here, let me know and I'll ask. Agoraphobia. Dom, do you want to talk about agoraphobia, and is it treatable?
Yes, it is treatable. And it's, it's one, I've talked a little bit about a thing called window of tolerance. This is where, when we're treating any anxiety condition, but particularly any condition where there's a big component of avoidance. So just to for anyone who's not aware of agoraphobia, so what it is, it's nearly always panic disorder underneath it, which is where a person develops such an intense anxiety related to going out of the house, and then of course it spirals. So as soon as they do go to the house, the anxiety gets worse. They go back into the house and feel better, and then it becomes harder.
And then you've got a circular circle of, well, I'll just stay in my house.
Yes. So we do work with it with what we call window of tolerance, which is finding a place where, you're going to be uncomfortable, you're going to have some anxiety, but making sure the person feels supported and has tools to work with that, and working very gradually to increase up what we call that window of tolerance, get them out of avoidance, but make sure they don't go into overwhelm.
There was studies where they did the immersion therapy.
They used to, we called it flooding, and it when you have a think about what it was doing to people's nervous systems, as well as just how uncomfortable it was. Now we work much more with what we call graded exposure. You can sometimes see, if you know what to look for, you can sometimes see people out with their therapist, where you've got the psychologist actually working with the person, really supporting them through.
Right, question, who diagnoses bipolar?
Psychiatrists.
It's
what's the divide between psychiatrists and psychologists? So we've got a medical degree, and then did our training in psychiatry on top of that, and so we do a lot more in the area of diagnosing the serious mental disorders, the schizophrenia, bipolar disorder, the ones that pretty well need to be managed by medication, and often can involve hospitalisations.
Jobs. With this list, you need to go to your GP and then get a referral to a psychiatrist. And fear of trying new medications, super normal. Of course you would be. Of course it would be scary.
One of the things with the stimulants that it does help to know is that a lot of the medications we use, you have to take it every day. It's a few weeks before we know whether it's working, and then it takes a little bit to get out of your system. The stimulants are they're symptomatic relief. They work while they're in your system, and once they're gone, they're gone. So for something like Ritalin, it's got a 3 to 4 hour timing of activity.
Right.
So, and you don't have to take multiple doses to work out whether it's right for you. So it really does decrease the risks associated with it from that perspective. If you take it and it's not a great one for you, it's 3 to 4 hours of uncomfortable and then it's out of your system.
We had Holly, my son is ADHD, always suspected autism too. But what are the different types of ADHD?
We don't tend to type it quite as much as we used to. It used to be hyperactive and inattentive, which was looking at where there was a lot more of the physical movement and activity related to it. But nowadays we do tend to just use ADHD. Sorry, we're just a little bit distracted.
Our sons are just over there. I'm just keeping an eye on them.
They've been absolutely amazing. They have been so patient and waiting. There's... And I'm getting to the
I know our words start to go after about an hour. Our words start to go.
But if you're suspecting autism, absolutely talk to the person who made the diagnosis of ADHD. They are often coexisting, and I think we talk a lot about here and what are the usefulness of labels. But most people who are late diagnosed would say, "I wish I'd known earlier."
Very useful, making sense of your own brain.
Making sense of your own brain, understanding why your brain might do things, understanding areas that might be harder for you.
Yeah.
When you're sitting there going, everyone else finds it easy, I should find it easy. It's very, that's
hard for
very
me.
demoralising. I've found it so much better when I have to go, it is actually hard for my brain to do this. It's just the
and
way
I
it
just
is.
go, I actually just can't do this. Hi, Bree.
Yep.
My brain actually just can't do this.
That. I'm going to have to find another way.
Won't do that.
Yep.
Or no, neurodivergent people actually do need more sleep than neurotypical people. Yeah, that's a real thing.
And sleep's incredibly important, particularly for kids, as to how symptomatic they'll be.
I love Toowoomba, Holly. I don't know much about their public system though, so I really can't.
We were having a discussion about this just before, actually, from the point of view of inpatient, inpatients and mental health. I think we just at the beginning of the talk and how much.
I'm so sorry, Dr. Dom is not taking any new patients on.
The thing with the public and private system in mental health is for everything else, whether it's orthopedics or heart disease and everything, the public system treats pretty well the same things as the private system. It might just take a bit more time. You might be in a shared ward. Within mental health, we're the one area where we actually treat very, very different conditions. So the
Bonnie,
public
thank
system
you so much for your support.
is
We're
focusing
so grateful.
nearly completely on psychotic conditions and very, very serious mood disorders, and then providing just very acute crisis management, whereas the private system's got a lot more capacity to work with depression, anxiety, trauma-related conditions. And that is one of the differences between the public and private.
Mango Jam, common characteristics of autism in older males. I mean, I feel like it's so varied. I don't know how we could... what would you say? Thank you so much, Holly. That's so kind. Because autism presents differently in everyone. Every single person's different. Every brain is different. Everyone's brain's wired differently. Thank you so much.
Oh,
Yeah, we're
thank you.
good.
It's really lovely to
That's
hear.
really kind. We're a good little. Is that my phone somewhere? Yeah, my son's starting to lose it a little bit. Yeah, Dr. Dom is very thorough. She spent all morning listening to a worldwide convention of women speak about psychiatry, mental health, all sorts of things, which is fascinating.
And look, part of what we're trying to do here, we want to decrease the stigma. I really, I love sharing about these areas because I know how much difference it makes when people have an understanding of what's behind it or why we're doing things. And in the past, there has been a little bit of that attitude of patients don't need to, and not it was quite a while ago, but it really helps people with their kind of autonomy and sense of making decisions and choices. But it just really, really helps. When we don't know what's going on, it's scary. When we've got the information, it's kind of like, oh, wow, that's actually really interesting.
Information is powerful.
There's a wonderful woman who works in anxiety education for children. She's out teaching 4-year-olds about their amygdala. And people are kind of like, oh, you can't use that kind of science language with kids. They love it. Absolutely adore it.
They love it.
Yeah.
They love it. And I would also say that because another massive focus for us is reducing shame.
Yes.
I say this all the time on my personal page as well. Every time someone shares a story, shares an experience, shares something about themselves, another person will see that, whether they commented or not, and they will go, I'm not alone in this.
Absolutely.
And it makes people feel less alone. So it's actually a really empowering thing to sit and to share.
I was lucky enough to be involved in some of the autistic, the groups on social media when there was that real kind of increase in people becoming aware of being autistic. And it was just amazing because it was kind of, oh, I do this. I thought I was the only one who did it. And I felt so weird about, suddenly it's like, yeah, no, I do it too. No, I do it too. It was just, and suddenly it was something that was a shared experience. Everyone was embracing it. It was kind of like, actually, that's pretty cool, rather than, oh, this is something I have to hide.
Jobs, neither Dr. Dom or I are taking on private clients, so I'm so sorry about that. I haven't listened to the Neurodivergent
I've heard
Woman
really good
podcast,
things about it, though.
But Dom and I filmed our first podcast 2 weeks ago, and it's already ready to. Hi, Sienna. We will talk to you in a second because I remember you. And the podcast is almost ready to drop. I might drop some little teaser trailers because it's me interviewing Dr. Dom, and her story is just, it's amazing. Hi, Sienna, because I remember you, so I want to check in on you. I'm not really doing okay because my favorite cousin doesn't want me in his life when the ADHD is hard. ADHD is hard. It can be hard for other people to manage it. It can be hard for you to manage it yourself. Most important things is to be kind and gentle with yourself, please. Be gentle with yourself.
Everybody out there, where it's possible, just really increase up the communication. So, there is a lot going on in the world at the moment. I don't know of anyone who's not struggling, stressed or really feeling, limited in capacity. And the difference it can make when we actually share with each other and are kind with people as to how what we've got going on or why we may or may not be able to relate to a person at a particular time.
Holly, we can't. So we can't recommend personal people, but there's a study that Dr. Dom has shown that when you look at the faces of psychologists, you'll get a really good read.
Your gut feeling is actually really accurate.
Your gut feeling about them.
Yeah.
So Google them, look at their face and trust that gut feeling.
And check whether they're trauma informed if that's something that's an important part of it.
Read the reviews and all of that stuff. But and Sienna, I'm so sorry that you're going through this. And I'm hoping that does the public system diagnose bipolar? Yeah, of
Yes.
course, the public system
They
is
actually
they're kind of frontline with the people because
Yeah.
they get admitted through.
Yeah.
Yeah.
I'll just talk a bit to people, it's, where emotional regulation is a difficulty, because it can lead to behaviours where something's, where you've done something that has affected or upset other people. And the more that we can decrease the
And we've all
stigma,
done that.
it really helps then to be able to do the repair work afterwards, but also then really being able to kind of dig down into, okay, what's going on from a regulation perspective, what can help.
Send me a little DM, Sienna,
Yeah.
and we can chat. Words going.
Yep.
Words going. We're hitting it. Sienna, send us a DM and we can chat in private.
Look, yes, there are a huge numbers of issues.
You can DM us here on NeuroKind, or you can
Yeah.
DM me on my personal one, which is hannah.claire.kaiser.
But yes, the public system and mental health is a constant struggle. There's been so many kind of, how do we work it? There's a lot of people with different diagnoses in there. There are often a lot of people who are in a very acute, dysregulated state at exactly the same time as other people who are there in a highly internal distress state. There are not enough beds.
Yeah.
There is an absolute flood of people in acute states, and where there isn't then enough help from a perspective of preventing kind of ongoing presentations. There are so many areas in that can actually lead to people coming out more traumatised than they went in.
So I think we'll just...
It's still important, if you are not safe, to present.
Yes.
To present and to get the help that you need. Yes, we've done our first podcast. It's in editing at the moment.
I might post some teaser trailers because some of them are ready. And Sienna, you're doing your best. Be kind with yourself. And everyone who's watching, you're doing your best. Be kind with yourself.
Okay.
Be kind to your brain and your other brains.
And thank you everyone for for the shift in time. We're really, really working to make sure we do get on once a week.
Yep.
And sometimes that does involve shuffling around different.
But we're making it work.
Yes.
So I'll drop some teasers from the pod and then we'll launch the pod.
I will just say, putting in complaints, absolutely. It's both telling your story and
Yay, Sienna, good
you may
for
not
you.
get a response that's really helpful or validating, but at least you know that you've been able to tell your story. Cool.
All right, okay, guys, we're getting off now. Thank you so much for the support. We're so grateful, and
We'll see you next week on Thursday.
Yeah, we'll see you next Thursday, and I can't wait for you to hear the pod. So, bye, everybody. Have an amazing week. Relax. Be kind to yourselves.